which is Dr. Moser from the CDC, and she's actually going to give us the U.S. CDC perspective on some of the...
Good afternoon. Let's see. It's a lot to negotiate here. Let's see. All right. Okay, am I supposed to introduce myself? Well, I'm not really a child TB person. I'm just a TB person. I ran the San Diego County TB program for about 20 years, and just a year ago, actually, moved over to the Centers for Disease Control, the Division of Global Migration and Quarantine. San Diego, we had one of the highest rates in the U.S., maybe not be too impressive to some of you. It was about 8 per 100,000, which is about 3 times the U.S. rate, about 300 individuals a year. And about 10% of those were pediatric cases. I think I have to hold it a little closer. All right. So for those of you who were at my talk yesterday, some of this is a repeat, but you only remember 10% of what you hear, so you'll know 20% by the end of it. And so I am going to talk about the screening strategies that we use now in the U.S., including adults and children. Let's see, which one? Yeah, it's a new one. I'll just raise my hand.
Next slide, please.
Next slide. I think the next one is my disclosure slide. I have nothing to disclose. There we go. Next.
This is not working.
I'll see it. All right. At you? Here, you do it. Let's see.
I'll do the slides.
And there we go. Okay. There. Thank you. All right. So we're going to talk about the pre-screening evaluation and follow-up for U.S.-bound immigrant and refugee children, and I'm going to talk just a little bit about unaccompanied minors. Next. Okay. So the U.S. has about 180 million individuals who enter the U.S. each year. Most of these are very short-term admissions, people who are just coming in mostly as tourists, maybe short-term workers. And so what I'm really going to talk about is the 70,000 refugees who intend to stay for long periods of time in the U.S. Now I think the cap in the U.S. is 50,000. And the million immigrants who stay for long periods of time in the U.S., about 500,000 of whom are screened outside the U.S., about 500,000 are screened inside the U.S., and I'm not going to talk about the folks screened inside the U.S. The places, go back. Who's moving these slides? So when immigrants and refugees are screened before U.S. entry, they're screened at about 300 to 400 sites throughout the world where the individuals either originate if they're immigrants or where they now live if they're refugees. Next. And this is, since 2007, this has been the algorithm whereby people are screened, both adults and children, and I'll explain. So from ages 15 and older, individuals are screened with a chest x-ray. And then if the x-ray appears to be tuberculosis, then they get 3 smears, 3 cultures. If any of those cultures are positive, they're given this designation of Class A, and they're not allowed to enter the U.S. until they're treated to cure using the American Thoracic Society regimens. And then they're able to enter the U.S. They're given a B1 classification. If they're smear and culture negative, then they are allowed to enter the U.S. immediately, and they're also given a B1 classification as non-infectious, untreated, possible TB. And they are presented in a way I'll show you to the accepting U.S. jurisdiction. Now, what about kids? So children from 2 to 14, if they're in a country that WHO has estimated on average 20 cases per 100,000 rate, then those kids from 2 to 14 are either skin tested or given an IGRA to determine if they have latent TB infection. And only then, those who are positive are then provided with an x-ray, and if positive, they go through the same algorithm as adults. Prior to 2007, children were not screened at all. It was really only 15 and older. Now, the important thing about this is there are very few children that actually end up being active TB and then notified to the U.S. What this has given the opportunity, so the reason kids are skin tested is because there was a policy that children couldn't be x-rayed like adults. And so there had to be a way to sort through the most at risk, and then they could have an x-ray. But what's really happened is it's pre-screened these children for latent TB infection, and they then, with this B2 classification, are then also notified to the receiving U.S. jurisdictions, so U.S. jurisdictions can sort of hit the ground running with prevention. So it sort of had a sidelight that was unintended, but excellent. So this, you can just somehow it, yeah. So this is the system by which health departments in the U.S. are notified. Right now it's all on paper, but thanks to Australia, who's managed to do this on an electronic manner, it will soon be electronic. But right now, immigrants, refugees, they actually bring in their exam from overseas in a paper form. They hand it to the border agent when they come in. The border agent, most of the time, gets the paperwork. It goes through a system with CDC where they actually enter the classification, and they know where the immigrant and definitely refugee, because they go through resettlement agencies, but they know where all these individuals are going or intend to reside in the U.S. And so that information through this system called Electronic Data Network, or EDN, makes its way to all the local health departments in the U.S. so they know who's going to arrive. And they're supposed to identify them and evaluate them within 30 days. That's the goal anyway. And local health departments, access to this system, they actually put in the results. Did they find them? Did they screen them? What were the results? And so we have a really nice data system to be able to see what happens to the immigrants and refugees when they come in. So I'm not going to talk about the active disease. There's very few, about 15% of all the individuals coming in are children. 15 to 20%, depending on the year. Very few cases of active disease in children. But here's the data about latent TB infection in one analysis among refugees only, and that's the best it can be because they have resettlement agencies who sort of take them under their wing. So there were about 6,000 kids over these 7 years who had latent TB infection. And you can see overseas, they have the opportunity right now to decide what tests they use. So it's still mostly skin testing, which may not be ideal, but it's still mostly skin testing right now. So you can see most of the kids were identified as LTBI with skin testing, a little bit with 2% with IGRs at the time. In the US, you can see how many actually had follow-up identified. About 80% of the kids actually made it to a health department and the evaluation started. The U.S. health departments more and more are repeating the testing when the child gets there. At this point, it was 30% using IGRAs. It's probably more at this point with IGRAs in the U.S. And so at the end of the day, about 63% of those kids that made it through the evaluation were identified as having latent TB infection. Next. And so for this study, basically the upshot was children who could benefit from LTBI treatment. Here they're being just presented to U.S. health departments, but they dropped out at multiple points along the path to treatment completion. So 21% didn't have follow-up. Of those who started follow-up, 10% didn't complete the follow-up. You know, skin test is 2 parts and then x-rays, and kids drop out along the way. 20% of those who were diagnosed with latent TB infection didn't initiate preventive treatment, and of those who initiated, 50% didn't complete, or 50% did complete. Next. And then they did the same kind of analysis from 2009 to 2015, so again, a 7-year period of time, but then they looked at, with the same EDN database, refugees and immigrants, the immigrant children. So again, you can see there were about 17,000 immigrant children, about 3,000 refugee children that were diagnosed with LTBI on their U.S. exam. But if you saw how many kids actually came in, it was about 60% of the kids actually made it to a point where they had a diagnosis. then there was about 60% of the immigrant kids and about 70% of the refugee kids. So the theme is refugee kids always do a little bit better than immigrant kids, because when immigrants come in, there's no one taking them under their wing but their family. And then you see almost 80% in this analysis of refugee children started on treatment for LTBI, as opposed to about 60% of the immigrant kids, and about 50% of the refugee kids completed the treatment, as opposed to about 45% of the immigrant kids. So this is, again, with TB programs being handed off people already LTBI screened, it's still very, very difficult to get people started and completed with treatment. Next. So one of the things that's being thought about has been so successful to treat active disease overseas in immigrant and refugees who are identified. The thought is, could we do the same thing now that we have a short course LTBI treatment, 12-week LTBI treatment? Could we actually treat people overseas where it might be a bit easier? So just now, the protocol isn't even completed. There is an idea to pilot among Vietnamese immigrants bound for the U.S. to assess the feasibility of short course LTBI treatment before they leave. Now, of course, this is fraught. I mean, when you get to the point that you have your health exam, that's the last step of a long path to get to the U.S. And so to have people sort of hung up for another 8 weeks or so may prove to be difficult. But that's why this is going to be a voluntary program to start your treatment, and they would need to complete at least 8 doses or 8 weeks of a 12-week treatment, and then they'd be given the rest of their last month of ionation ribapentine, in this case, to bring and be connected with their U.S. Health Department. So this will just get off the ground next year. And then just, I'll tell you all I know in about 5 minutes about unaccompanied children. So right now I have to say that in the U.S., the official term is unaccompanied alien children. I will refer to them as UACs. So an unaccompanied, I'll call them unaccompanied children. Unaccompanied children are any who come into the U.S. who are unaccompanied. They are not with a legal guardian, they are not with their parents, and they are 0 to 17 years of age. So they come into the U.S., and when they are identified, either and usually crossing into the U.S., and they usually just give themselves up at the border, and but sometimes they're found within the U.S. Whichever way, they are then turned over to Office of Refugee Resettlement. It's not within the CDC; it's a different U.S. agency. They're they're notified to the Office of Refugee Resettlement within 3 days, and then the Office of Refugee Resettlement are the ones who are then responsible for the care and safety of those children. Next. So this has become a big thing in the U.S. because the numbers escalated started in 2013 and really went up years after. There have always been unaccompanied children coming in the U.S., but until it really, doubled and tripled and quadrupled, it wasn't really something that came on people's radar screen. Most of these kids came from Central America. You can see Honduras, Guatemala, and El Salvador. There are a lot of theories why: violence in the country, thoughts that the U.S. was going to change immigration policy. I don't know all the reasons, but it was so. Next. So you can see most of the kids are older children in the 15 to 17 year age group, but there are some like little kids who also came in as unaccompanied children. Okay, helping them. And so what is the Office of Refugee Resettlement responsible for? Well, the care and custody of the children, and the way they do it is they work through a series of hundreds of shelters. So they contract with these shelters, and the shelters house the children, and the shelters then generally subcontract for health services with providers in the community. And these are short-term stay. So the goal really for Office of Refugee Resettlement is to reunite children with relatives in the U.S. or some other caretaker for the children. So usually the stay is less than a month. And the medical care is is they try to catch them up with their immunizations, do other emergency and necessary care. But for TB, what they do is they screen them for active TB in the same way, basically overseas. They, next. They, for kids 5 and older, they suggest, but it doesn't always happen, using interferon gamma release assays for the kid under 5, as is U.S. recommendations now. They use a TB skin test. And then if they prove to have active disease, the local health department is involved, and no matter where that kid goes in the U.S., they have very good completion of therapy. There's a very tight system for referring people throughout the U.S. from health department to health department. The problem comes if they turn out to have LTBI. Because it's a short-term stay, they aren't going to start or complete them. And so what they do is they send, once they find a sponsor, they send a letter to the sponsor saying this is what the child has. They send a letter to the health departments. When I was in San Diego, we got about 5 or 6 of those letters saying this child is living here. They have a positive skin test, a positive IGRA, and there you go. And so these are the number of active cases, very small numbers. It ends up to be a case rate of something like, let's see, so it'd be 190 per 100,000, a high case rate, but not a lot of cases actually found. There was 15 over 2 years. And then this is the LTBI. So there was about 10% of the kids, more or less, had latent TB infection. None of them started on treatment. All of them referred out. So in any year, there's about 60,000 kids. So that's about 5,000 to 6,000 kids a year with latent TB infection. And so that's my conclusion. I think we have very strong strategies in place to evaluate these children, but there is a lot of work needed to do with latent TB infection and providing that. The good thing in the U.S. is that U.S. Attention has been swinging as our rates of TB are now 3 per 100,000 nationally, has been really swinging from disease to infection. So it's a big, huge push in the U.S. So hopefully there'll be a lot of strategies here soon. So thank you.
So we actually, if anyone has a question for Dr. Moser.
In the unaccompanied children, I have heard, this is not official, but I've heard rumblings that some kids are starting to have a tad longer stays. So I'm hearing that they may start to try to apply that to the unaccompanied children. Yeah. Yes.
I was wondering about cost effectiveness because according to what I tried to calculate, about 20% of the children who had LTBI more or less completed the treatment.
Yeah.
I wonder whether it's worth all the hassle or whether it's worth investing more in making them to complete the treatment, which is
Great question.
Right. So the cost effectiveness, many people wonder that, of screening the children overseas and then not having them really complete once they get to the U.S., right? So again, the reason for screening children like that was to get around the policy of how then do we screen children for active disease. So they had to start with a screening for latent TB infection. That being said, many people in the TB community said, wow, what an opportunity that we're missing. So that is one of the reasons to say, could we do this overseas if it doesn't hang up the people too much from entering the U.S.? But the other thing is there are many things I think that we can improve inside the U.S. One of the things we're working on is really doing an education campaign, because a lot of time if someone tells you you're a B1 or a B2, what does that mean to you? So I think educating people better when they're overseas, and getting a warmer handoff to the U.S. programs in the U.S. So I think you're right. We have a long way to go.
So the original work on the cost effectiveness was done by Kevin Schwartzman, that's at McGill, and they published that work in 2006, I believe, and he actually showed that there was much more cost effective from the U.S. perspective to actually develop this program overseas, which was really the evidence that moved to the new TBTIs and the TB treatment guidelines that the CDC Office of Quarantine Migration uses. But the other thing that he emphasizes is that any intervention whatsoever we use, the cost effectiveness of it is magnified if people actually complete treatment, period. So what you're saying is with the low rates of LTBI treatment completion, it does affect the cost effectiveness of it. But this overseas screening, there's a lot of evidence to show for the U.S. it's very cost effective. So we're going to move on to our next speaker, which is Dr. Maureen Sakade. And Maureen is going to give a perspective from a TB high burden country. Did you wanted to say a bit more? Did I stop you? No. Okay.
Sakade, and I am a pediatrician and with additional training in public health. I'm based at the National TB and Leprosy Program in Uganda, and I'm here to share about expanding access to integrated childhood TB care and prevention in Uganda, and probably at the end we'll see how this really relates to child TB among migrants. So for us who do not know where Uganda is that little country in red in East Africa. We do have a very high burden of tuberculosis, 234 per 100,000. Our HIV prevalence among the children is now at 0.5%, and our co-infection rate is high at 42%. So I just wanted to flash this to really summarize how our childhood TB program has evolved. We did start in 2012, and this was as a result of identification of the problem. And we have really developed guidelines. We have a technical working group, and we have gone on to build capacity for health workers. What I have to say is that child migrants in Uganda access the same care as the locals. So we do not really have a differentiated service delivery. So they access the same services as the locals. Our childhood TB case notification is standing at 8.2%. This is really low compared to what is expected. Publication by Dodd et al. In 2014 put us at about 17%. So we are clearly missing 50% of children that have tuberculosis. So my focus is going to be on innovations that have really we have put in place to increase TB case finding among children. And I'll focus on the Detect Child TB project, which was supported by the Union together with the Ministry of Health, Baylor Uganda, and Mildme Uganda. And it was really focusing on decentralizing child TB services in order to increase case finding and TB prevention among children. The other innovations that are going on ICCM, which Poonam really pointed out that is important for us to really integrate migrant health, and the HOPE project, which is funded by CDC through Baylor Uganda, and is also aimed at increasing case finding. So the Detect Childhood TB project really stands for decentralizing TB services and engage communities to transform lives of children with tuberculosis. And the project goal was to strengthen health facility and community level healthcare delivery to improve childhood TB case finding. We did this study in 2 districts, one which is Kabarole, which is a rural district, and Wakiso, which is a peri-urban. The project objectives were really to improve capacity of health workers to diagnose TB, to increase case detection among household contacts, and to prevent tuberculosis among those children that are at risk, as well as improving outcomes. So Kabarole district is a rural setting that has, it's more of tea workers, and we do have the adults in Kabarole undergo what is called a seasonal migration. So we do have 2 seasons in the country, rainy season. So during the planting seasons, the parents or the caregivers will move on to the tea plantations, but they do not move with their children. So the children are left at home to be cared by the other family members. As I mentioned initially, the population accesses the same care as everyone else. So DETECT really started, the approach begins at the health facility where an index TB case is diagnosed. So these index TB cases are requested for information on the location of the home. And we have what we call community health workers that move on into the community to assess the household members for tuberculosis. Those that have symptoms of tuberculosis are referred to the facility for further evaluation. Those that are asymptomatic and eligible for preventive therapy are also sent to the facility for preventive therapy initiation. So what this study has shown us is that it is possible to decentralize TB services. If you look at the district, I'll focus on Kabarole district. At baseline, we found that majority of the TB cases, that is the blue, were diagnosed at the hospital level. Really, the services were centralized. As we implemented the project, we brought services closer to the community. And you see that the gray, which is the health center 3s, were able to diagnose tuberculosis in children. So it was possible to decentralize TB services. And so the challenges that we had limited resources. We documented limited resources by the caregivers to take the children to the facilities for further assessment. And it was challenging for the caregivers to really understand the importance of preventive therapy. These are well children, they are playing, and we are starting them on preventive therapy. So a lot of counseling was actually done for these caregivers to appreciate. At health facility level, there is a limited confidence in diagnosing tuberculosis in children. At that time, we did not have access to child-friendly formulation, but now the situation has changed. We actually brought in the new formulation, 75, 50, 150. And we did have interrupted supplies of isoniazid preventive therapy, as well as a weak sample transport system. So the lessons that we've learned is that it is feasible to decentralize childhood TB care, and especially if you work with the communities. If you involve the communities, it is possible for these services to be provided. And working with the communities creates trust and ownership. So in the context of childhood TB among migrants, it's important to work with the people that they are used to in order to improve trust and have a follow-up thereafter. Clinical diagnosis is key in improving childhood TB case finding, and the project documented success in initiating isoniazid preventive therapy. We started 87% of eligible children by the project end. And we also demonstrated that it's important to have a public-private partnership. As I mentioned, for us all, refugees, migrants access the same care. If they are well-to-do, they'll go to the private sector. If they do not have enough resources, they'll go to the public sector. So it is important to really have that partnership to improve our case finding. We also documented spillover effect. While we focused on a pediatric tuberculosis, we documented that there was an increase in the number of adults that were found to have tuberculosis. So how does this relate to the context of child TB migrants? We do know that, beyond my country, there are issues to do with the health system, healthcare coverage, issues of insurance, and the child TB migrants really have limited access to that. We do know that they also have issues to do with knowledge gaps, misconception, stigma, and marginalization. And they really do not have access to proper housing. They live in crowded situations and really limited family support. And issues also to do with documentation. So the strategies that we really have to put in place would include clear policies and guidelines. In my country, our national strategic plan, our guidelines have included refugees and in-country migration population to be really targeted for integration of TB services. We are now working closely with UNHCR to really strengthen the refugee, including refugees among the service provision. And the country is also now developing a strategic plan to address issues of refugees. And 2 weeks ago, we were actually in the refugee camps trying to document the access, the services that they have access to. It's also important to have a multi-sector collaboration beyond health, and really this includes labor as well as immigration. And differentiated service delivery, it's not a one-shoe-size-fits-all. So it is important for us to tailor the services to the needs of the particular population that we are looking at. And it's important to have integrated community-based interventions. Our study showed that if you roll this out to community level, you're able to improve services. And with ongoing community packages that we have nutrition, we have focused antenatal care that is provided in the community, immunization. It is possible for us to integrate these services and target the child TB migrants. I wish to acknowledge those listed in no particular order. Thank you very much.
Thank you, Maureen. Any questions or clarifications for this talk from Uganda? If none at this time, then we will move on to Kenya. We have Immaculate Kathure. I hope I'm pronouncing your name right. By case finding, diagnosis and treatment of TB amongst migrant and refugee children. Also focusing on the rollout of fixed dose combinations in the country. So Immaculate.
So good afternoon, everyone. I'll start by saying, I guess the idea of moving rooms goes a long way to say what we really think about children with TB. For me, I take that very personally because I believe a lot of the time we assume children are little adults. Therefore, we make these big shoes and cut them up in little pieces and hope all the children will fit in them. And I think that needs to change. Now, back to my presentation. So I'll start by saying that my name is Dr. Immaculate Kathure. I work at the National TB Program in Kenya, where I'm responsible for TB care and treatment and also childhood TB. Been working there for quite a while. Now, the TB program in Kenya is an all-encompassing program where we deal not just to the population of Kenyans that are living within the country, but you also have a lot of migrants that are in the northern frontiers of our nation, and I'll be talking a bit about that. Next. So just as an introduction, we have Kenya as one of the 30 high-burden TB countries with a high burden of TB, TB HIV, and DRTB. Now, Kenya is a country of about 42 million people with 3 main refugee areas. We have refugees coming from some of our surrounding countries where there is a bit of war. We have a few refugees coming in from Somalia, from a bit of Ethiopia bordering South Sudan, then some coming in from South Sudan. Internally, we have what we call internally displaced persons, but right now I would be happy to say that those are not very many, so I didn't do a lot of data on that. Now, when we look at the biggest refugee populations, we have them in Kakuma and Dadaab. Now, Dadaab camp has been one of the biggest camps that we've been having, but that was closed down along the way. And so I'll be focusing a lot on Kakuma. Now, when you look at the population of refugees in Kakuma, about 180,000 refugees, we're seeing the population of children actually is about, sorry, may I have the point? This one. Okay. No, the highlight. Oops. Sorry. Yeah. So we have about, most of our children actually being below the age of 17. Most of our refugees being below the age of 17 years. Now, when you look at the history of TB in children, we know that children, by nature, are immune suppressed. So every time they're exposed to tuberculosis, they're more likely to contract an infection. When they get an infection, they're more likely to progress to disease. And so with our population of refugees being mainly the young population, and especially 0 to 4 years, then we are having a problem in our hands. And we're also saying that among the drug-sensitive TB cases reported in Kenya in the year 2016, 16% in those refugee, the facilities that serve the refugee populations, 16% were children below the age of 5 years. So basically we are saying we have a huge problem of TB among our migrant children. Next. Okay. So if you look at the migrant population and TB risk, and I would want to contrast this to some beautiful photos of a home where migrant children in the US were staying, and contrast that with the beautiful shelter that the migrant children in Kenyan refugee camps are staying, we're saying that there's a lot of overcrowding and malnutrition, which are major drivers of TB disease in every population. So we're saying that apart from that being prevalent in the population, then in the migrant population, these children are actually overcrowded. As you can see, one shelter can house up to 10 children or up to 15 persons. Then you also have a lot of malnutrition in these children, because right from where they fled from war-torn countries, places where they were not able to access food and other services, they already are malnourished. Then also majority of the migrants are children, therefore they have a higher risk of infection. They are more vulnerable because of family separation. They also have poor access to treatment, because sometimes when they get separated from the adults that they're used to living with, and they come to a camp and they're just children living in a shelter, if any of them falls sick, their ability to actually look for health services is limited. So by and large, they'll be depending a lot on the minders that are within the camp to be able to identify a sick child in that shelter. Now, the countries of origin already have failed health systems. These are countries where TB burden is very high, but for quite some time, they've not been accessing services in their own home country. So at the point when they are fleeing, some of them already have symptomatic TB disease. Some already have latent TB disease. Now, with malnutrition, reactivation of the latent disease is very prevalent. Then this results in an increased risk of TB morbidity and mortality among these migrant children. So what are the challenges with TB treatment in these children? First is the high literacy levels among caretakers. Remember, these are countries where systems have failed. Basically, there are no schools, there are no hospitals, people don't go to school. So at the point when they are fleeing, the people they are fleeing with may themselves be not very literate. The children themselves may never have had a chance to get an education. And if they did, may not have been the very best quality of education. Then some children are separated from their families during flight, and therefore we have what we call child-led families, where you find children find each other, or they fled together, their parents were killed, or their parents were lost or displaced, or parents ended up in a different camp, or they could be in the same camp, but with 200,000 people, may take a bit of time for them to actually meet their caretakers. And then we also have we initially had a very complex treatment regimen. Now, when you talk about treating TB in children, we use the same fixed dose combinations regimen that we use for adults. That is 4 drugs in the intensive phase and 2 drugs in the continuation phase. The initial regimen that we used was actually 3 different types of drug combinations to make the 4 drugs in the intensive phase. So this caregiver has to give the RHZ, the old formulation, they had to give RH6060, and they had to give ethambutol, and none of these were dispersible. Now, sometimes you'll find a child is taking 2 tablets of one pill, 1 tablet of another pill, and 3 tablets of another pill. Even for someone who's gone to school, that is not very easy to remember. And if the household has more than 1 child who is unwell, now creates a disaster. If I have to remember 3 different formulations for 1 child, if I have to remember 3 different formulations for 2 children, those are 6 different, and maybe I also have my own medicines. It just creates a crisis in treatment. Now, this complex treatment has to be given for a duration of 6 months, and dose approximation is very poor. Why? Because the original tablets every time we had to approximate doses, especially for the younger children, we either had to break the tablets or crush them. Now, they were not very easy to break. They were not very easy to score. Half the time when you're breaking, a piece flies off the room and you're not quite sure what proportion of that tablet you've actually lost. So we ended up with a lot of poor dose approximation for the children that were being treated. What did this lead to? There was very low case detection. There was also very poor adherence because the tablets are not very palatable. The regimen was very complex, resulting in higher mortality and a higher risk for development of drug-resistant TB in these children. Then came the new formulations. 2016, Kenya was among the first few countries to roll out the use of the improved formulations for children. This was done alongside very intense healthcare worker sensitizations, and the sensitizations went beyond helping the healthcare workers be able to administer the drugs. We actually focused on getting the healthcare workers to suspect and diagnose TB in children. This was done nationally, and there was also a lot of focus also on the healthcare workers that were working within these migrant camps, the Dadaab, the Kakuma, and Koloyo Bay and Nairobi camps, where these healthcare workers were actually sensitized to be able to suspect TB in a better way and be able to diagnose the same. Now, when you look at the new formulations, they come in the correct WHO recommended dose. So we are no longer splitting and approximating how many tablets of each we have to give. Then that makes the regimen less complex. Why? Because now we have to deal with one fixed dose combination and then ethambutol, so completely simplifying the regimen that these caregivers have to give. Then it's also very easily dispersible and they're pleasant tasting. What does that mean to the migrant children? Because of the healthcare worker trainings, there was a lot of early case detection and treatment of TB in these migrant children. We're saying that unlike other situations where now they had to passively wait for the children to come and tell them they're sick, when the childminders and the healthcare workers are actually screening even the refugees at the point of entry, now they were better equipped to actually look for TB in the children that were coming in. They're also better equipped to look for TB in child contacts of adults who came in symptomatic for tuberculosis. Then we also had fewer pill combinations. This means where we had caregivers who are not very literate, and better still where we had caregivers who are children or the older children, then it's easier for them to understand what it is that they're supervising as treatment for the other children. The pleasant taste and the dispersible tablets meant that it was much easier to give. I cannot imagine a 14-year-old having to crush pills to give to their 2 or 3-year-old sibling. But dispersing a tablet in a glass of water, I think, makes much more sense for them. Now, this better approximation resulted in reduced risk for drug resistance. And with timely diagnosis and appropriate treatment, then we are also saying that this disadvantaged population of children are actually going to enjoy better treatment outcomes and have less risk for development of drug resistance. Now, one of the things that I did not talk about because I was basically focusing on the new formulations is the fact that among these migrant children, we also have a very high burden of drug-resistant TB. Now, you can imagine the complexity of treating drug-resistant TB even in a normal population. Now, the same, even in a migrant population, becomes a big challenge. So what are we saying? That just because a child is a migrant, just because they have a high risk for TB, and just because they have a complex treatment regimen, means we're denying them opportunities to be great men and women of tomorrow. I mean, great sportsmen and women, great innovators have come from these migrant camps. So every time we have to have better treatment, better diagnosis, and improved quality of care for these children, we're actually creating a better tomorrow for them. I think that brings me to the end of my presentation.